Welcome back. This is the third and final installment of my discussion on the physiology of motor system. In this lecture, I shall be discussing the gist of motor control, the effects of transection and hemisection of the spinal cord, and the differences between upper and lower motor neuron type of paralysis. Motor control. All motor activities of our body, if it is voluntary, is under a strict control. Uncontrolled motor activity is basically pathological. It can be as benign as a tremor or it can be as florid as a convulsion. If it is uncontrolled, it is pathological. So any voluntary motor activity is controlled. Now this motor control has a three-tier system. Firstly, there will be planning, then there will be a programming, and then execution. Different parts of our central as well as peripheral nervous system are involved in this planning, programming, and execution of motor activities. Now, first of all, what is motor planning? Motor planning simply means the framing of the correct motor ideas to accomplish a given motor task. So, to accomplish a given motor task, you need to have a pre-framed correct motor idea. Without a pre-framed correct motor idea, it is difficult to accomplish a given motor task smoothly. Example: I am taking your class. I am standing in front of you, and I know after I deliver a certain part of my lecture, I have to go back to the blackboard and write something. So I already know what is my given motor task. My given motor task is to go back and write something on the board. And to do it smoothly, even before I am doing it, I need to have the framing of the correct motor ideas ready. And what is that? First of all, I have to turn because I am facing you, and don't reach the blackboard straight away. I have to go towards the place where the chalk is. Pick up the chalk with my dominant hand because I am going to use it to write. Then reach the blackboard and then start writing. So that is the correct motor idea, and it has been framed and ready in my mind so that I could do the job smoothly. Now, sometimes when we are not ready with the correct framing, we land ourselves into trouble. For example, you are an intern on the first day of medicine ward round. You're very happy, you're smiling and standing behind the postgraduate trainee. Now the consultant suddenly asks the postgraduate trainee, what is the blood pressure of this patient? And the postgraduate trainee said, oh sir, the blood pressure machine was non-functioning or malfunctioning at that time. I have sent it for repairs. I think it is ready now. And he suddenly turns towards you and says, hey, BP machine ta niya to? And you are totally flummoxed. You don't know whether where the BP machine is, whom to ask, who already has it or not, how many BP machines are there in the ward. So you are standing and you have no clue what to do, though you have been given a motor task of going and bringing the BP machine. Since you do not have any frames, you cannot work. So framing of the correct motor ideas is essential to accomplish a given motor task. Which part of the brain is involved in such framing? It has been found by imaging studies as well as functional neuroelectrophysiological studies that the posterior parietal cortex of the dominant hemisphere is the area which mainly accomplishes this motor planning activity. This posterior parietal cortex, also known as the sensory association area. So if you are a right-handed person, the left-sided posterior parietal cortex of yours is accomplishing all the motor planning. Now if the job is a bilateral one, that is involves bilateral motor movement, the planning again is done only on the left side for the right-handed person. The right hemisphere gets the idea through the anterior fibers of the corpus callosum. So motor planning is done by the posterior parietal cortex of the dominant hemisphere. If the job is involving only one arm or one limb, then there is no need for the corpus callosum as such. But if it involves bilateral movement or bilateral involvement, then the left-sided hemisphere conveys the idea to the right side through the anterior part of the corpus callosum. After motor planning comes motor programming and execution of the motor activity. What is motor programming? It means the setting of simultaneous or sequential commands to be issued to definite skeletal muscle groups or single muscles for performing an activity. So firstly there was a planning, thereafter there will be a programming, and the execution of the activity will be based on that programming. Here I would like to mention that motor programming and execution is not strictly sequential. Means motor programming and execution occurs somewhat hand in hand, with scaling and correction activities going on. As the execution occurs, the program is reprogrammed and further modifications are done based on the feedback from the peripheral centers. Motor programming involves 4 steps. Firstly, after there is a plan, there has to be a program to execute the plan, that is formulation of the program. Then that program will have certain sub-programs, and there should have been a sequencing of those sub-programs. Thereafter there will be a scaling, means once the program starts executing, there will be certain modifications needed based on the feedback received from the peripheral centers, and the activity needs to be scaled according to such feedbacks. And if the feedback suggests any correction, there will be a correction of the motor program. Let me elucidate with an example. Let's go back to the example which I gave for motor planning, that is while I am taking the class. I was taking your class standing in front of you, and then I had to go back to the blackboard to start writing something. That was my motor activity. From taking the class, then stopping and going to the blackboard to write something. So what was the motor planning? That I have to turn, then reach the place where the chalk is, pick up the chalk and start writing. That is the plan. Now what is the full programming? Full programming involves I have to turn towards the side where the chalk is. If it is on the right side, some muscles of my body needs to relax while others needs to contract. So that is the first part of the programming. Then I have to take a few steps, say 3 or 4. I know that because I know how much my leg span is, or span of my each step is. So I can make out before I actually take the step how many steps I have to take. Say 4 steps to reach, then reach out with my hand, then pick up the chalk, and then again take 4 or 5 steps, reach the blackboard, slightly turn towards you, then start writing. These are all the formulation of the program. Each part might have a sub-program, or some parts might not have a sub-program. For example, when I turn, since I was speaking to you on a microphone, I was holding it on my left hand, say, and I have to turn towards the left. So the turning, which is the main program, has a sub-program of transferring the microphone from the left to my right hand. That needs to be sequenced too, because if I do not sequence the sub-program, if I start turning suddenly without transferring my microphone from the left to the right, my legs might get entangled with the wire of the microphone. So sequencing of the main program and sub-program is important. Now I am actually executing the program. I have now started turning and taken one step, and suddenly I realize the floor is too slippery. Though I have programmed the original 5 steps approach to the chalk, now I see the floor is slippery. I cannot go that fast. I might embarrass myself by slipping. So I immediately scale down my steps span, and now I have programmed my step so that I can reach the chalk about in 8 steps, and also from the chalk to the board in 8 steps. Now I have reached the blackboard. I am doing everything. Since it is very sweaty, a bit of sweat has entered my eyes. My program was originally to write on the board, but suddenly there needs to be a correction because I do not want to be embarrassed by this writing wrong things because I cannot see. So now I have to stop the program, take off my specs, clean it properly, put it back, and then start writing again. So that is the correction part of motor programming. So scaling and correction occurs when the execution is already going on. Formulating and sequencing the programs occurs before the execution. Scaling and correction goes hand in hand during the execution of motor program. Now, what are the different parts of the central nervous system involved in this motor programming? Firstly, the formulation of the program is done in the motor cortex, which involves the primary motor, the premotor, as well as the supplementary motor areas. So these are the areas which are involved in formulating the program. Then the caudate loop of the basal ganglia, which you have already been taught, and a part of the cerebrocerebellum is involved in the sequencing of these programs. So these programs have been formulated, they have been sent to the caudate loop and the cerebrocerebellum. They sequence the program in which they need to be run. After the formulation and sequencing has been achieved, the run button is pressed and the execution of the motor activity starts. Now, as the execution starts, the medial and lateral motor systems, which I have discussed earlier, are recruited to accomplish the activity. Now, accomplishing a motor activity involves muscle movement, joint movement, movement of head, movement of eyeballs, and other factors which are actually getting inputs into the central nervous system. Now, if those inputs suggest that the motor programming which was done originally needs to be scaled, then the putamen loop of the basal ganglia comes into action. It is involved in the scaling of the intensity of the motor movements. Just like in the example, the original step count was programmed to be 5, but since there was a feedback from the proprioceptive inputs regarding the slipperiness of the floor, the scaling was done and ultimately it was programmed that the person or that myself is going to take 8 steps to reach the chalk. Also, there is the spinocerebellum. The spinocerebellum, if you remember, you have already been taught, is continuously receiving the inputs from the proprioceptive, visual, somatosensory and vestibular apparatus, and it continuously refines the motor programs, and if any correction is needed, it immediately performs the correction and informs the medial and lateral motor system that the original program needs to be abandoned and the new program is going to be run through the spinocerebellar correction mechanism. So this is about motor programming, and as I have already said, execution, it involves simultaneous or sequential use of the medial and lateral motor systems. Also, there is a very complex interplay of different spinal and postural reflexes. The different reflexes you will learn when you will be taught the mechanisms of maintenance of posture and equilibrium. The neck writing reflexes, the head writing reflexes, the vestibular reflexes, the ocular reflexes, they all have a complex interplay for ultimate execution of motor activity. The next section of our discussion is spinal cord injuries. By now, I hope you have a basic idea about the structure of the spinal cord itself, its beginning or origin, its termination, what are the dispositions of the different spinal nerves, what is the disposition of the gray matter of the spinal cord, which is occupying the central part, having a butterfly like pattern, the disposition of the white matter of the spinal cord, the different funiculi, the dorsal or posterior funiculi, the lateral funiculi, the anterior funiculus, and so on and so forth. Those things I am not going to discuss because they have already been discussed in detail in anatomy and other classes of physiology. Next thing I want to say is this spinal cord injuries in itself can be a chapter or a book. The details of spinal cord injuries you shall be studying in your orthopedics class in your 3rd Prof Part 2 syllabus. Even those details will be very minor if you do a MS, or that is a Masters in Surgery in Orthopedics. So whatever I am going to discuss today will be just a little curtain raiser to the actual chapter of spinal cord injuries. So let's begin. I will be only discussing the complete and incomplete transections of the spinal cord. By transection means cutting, going through the spinal cord in a horizontal plane. It could be complete, means the spinal cord has been sectioned completely, one half is above and the other half is below. Or it could be incomplete, means there has been a cut but it hasn't cut the spinal cord through and through. Now what are the principal causes of transection of spinal cord? First of all, the most common cause of spinal cord injury, whatever injury is, whether it is transection, whether it is incomplete or complete, there are different other kinds of spinal cord injuries. The road traffic accidents are the most common worldwide. Thereafter, gunshot or other violent injuries or war injuries. Then penetrating trauma, which could be accidental or homicidal or suicidal in nature. Fall from a height, which could be as small as fall from a bed to the floor or from a high-rise building to the ground. And sports injuries. If you have fallen awkwardly on your head, on your neck, on your back, there could be injuries to your spinal cord. Complete transection of the spinal cord. As the name suggests, it is a complete through and through cutting of the spinal cord in the horizontal plane. And obviously, it is the most severe variety of all spinal cord injuries. In general, the effects can be described as there is loss of all sensory and motor functions from below the level of the transection. This is a very generalized description. The description of a complete transection of the spinal cord actually depends upon the timing from the injury, because there are different stages of a complete transection of a spinal cord. First, there will be a spinal shock, then will be a recovery of autonomic functions or reflex recoveries, then again there will be a loss of the reflex recoveries and abnormal reflexes coming into the picture. I won't go into those details because they are very complicated for you to understand at the present setting. Those you shall be learning in your third prof. For you, the basic thing to know is all sensory and motor functions are lost from below the level of transection, or in other words, the clinical manifestations depend upon the level at which the transection has occurred. Now, if the transection has occurred at the cervical level of the cord, then there will be certain manifestations at the thoracic level, certain manifestations at the lumbar level, different manifestations, so on and so forth. Usually, quadriplegia or the paralysis of all four limbs. It could be complete paralysis or it could be partial paralysis of the upper limbs with complete paralysis of lower limbs. It could be a wide variety of clinical settings depending upon which part of the spinal cord is transected. But in general, quadriplegia or paralysis of all four limbs is seen if the injury occurs within the cervical segments, means between C1 and C8 segments. If there is an injury between the first and 8th cervical segments, there will be quadriplegia. While there will be paraplegia or paralysis of the lower limbs only with sparing of the upper limbs, and this occurs when the injury is between the thoracic and 4th lumbar segments. So if the injury is affecting the cauda equina, then there won't be much paraplegia. So if there is a paraplegia or paralysis of the lower limbs and the upper limbs are spared, the injury will be between the thoracic and the 4th lumbar segments. In this table, I have summarized the effects of transection of the spinal cord at various levels. The table might look a bit exhaustive at first glance, but if you go through the table systematically, you will find it is rather easy to remember. Firstly, I have divided the site of lesion of the spinal cord into 6 broad headings. Firstly, a lesion between the first 4 cervical segments will have its own effects. Thereafter, a lesion between the 5th and the 8th cervical segments. Then a lesion at the level of the 8th cervical segment. Then at the upper thoracic segments between T1 and T6, and then the lower thoracic segments up to the second lumbar that will have other effects, and below the level of the second lumbar. So these are the 6 broad headings in which I have divided the site of lesion of the spinal cord. So what are the effects? The effects can be multiple. If you go through higher textbooks, you will find many effects, but broadly I have divided into sensory effects, motor effects, effect on vasomotor tone, effect on respiration, and few other important effects which are important academically for you. If you want to study more, you can go to higher textbooks. You will find numerous things written about the effects of transection of the spinal cord. But for all practical purposes, for first Prof MBBS level, I think this will be sufficient. So sensory effects. What happens if there is a lesion between the first 4 cervical segments? There will be global anesthesia, means global loss of all sensations. Means all sensations of the body will be lost, but the face will be spared because the sensory inputs of the face is through the trigeminal ganglion, which is not a part of the spinal cord. Thereafter, means if the lesion is below C4, then the anesthesia will be only below the level of the lesion. It won't be global. So whatever be the level of the lesion, the anesthesia will be from below the level of the lesion. As for motor effects, I have already discussed it. If the transection is between the first 8 cervical segments, there will be quadriplegia, while below it, from the thoracic segments downwards, there will be paraplegia up to the level of the 4th lumbar. As for effect on vasomotor tone, see, this vasomotor tone is dependent on the sympathetic outflow. There are cervical sympathetic ganglia, or more appropriately the superior, middle and inferior cervical ganglions, which give sympathetic outflows to the cardiac plexuses and also to the smooth muscles of the different large arteries and arterioles. Sympathetic outflow also comes out from the thoracic and lumbar segments and goes to the blood vessels and other structures receiving the sympathetic system. Now, if there is a lesion up to the level of the upper thoracic segments, due to the cutting up of the outflow from the spinal cord to the cervical ganglion and the thoracic ganglions, there will be a marked fall in blood pressure. While if the lesion is below the level of the T6 but up to the second lumbar, means the lower part of the sympathetic outflow, there will be fall in blood pressure, but it won't be that marked because the cardiac plexuses and large arteries will be spared. While if there is a lesion below the level of the second lumbar, there will be no effect on the vasomotor tone and no fall on blood pressure. Effect on respiration. If there is a lesion between the first 4 cervical segments due to the paralysis of the diaphragm, which is receiving the nerve supply from the phrenic nerve, there will be respiratory muscle paralysis. But if the lesion is below the level of 4th, that is between C5 to C8, respiratory muscle paralysis will be very negligible. Now, others, there are many effects that can be discussed, but basically if there is a lesion between the first 4 segments, it is usually incompatible to life. That is, the subject dies. If not very lucky and very immediate resuscitation has been done in the form of stabilizing the neck, the person usually dies of the transection. Thereafter, the situation is salvageable if proper medical attention is given. One important question that you face is Horner's syndrome. What is Horner's syndrome? It is a collection of few clinical features that occur because of lesion to the cervical ganglions. It is characterized by meiosis, that is constriction of the pupil, enophthalmos, that is indrawing of the eyeball inside the orbital socket, pseudotosis, that is drooping of the eyelids because the downward support from the eyeball is not there, hence the eyelids droop. Then anhydrosis of one half of the face, means loss of sweating from one half of the face and loss of reflex known as the ciliospinal reflex. If the lesion is between the 5th and 8th segment, the features of Horner's syndrome, not all of them are seen. But if it is just at the level of the C8, a full Horner's syndrome is seen. The importance of this you will understand if you go through the anatomy or surgical anatomy of the cervical segments. So this is about the effects of transection of the spinal cord at various levels. Incomplete transection of the spinal cord. As the name suggests, it is a section but not through and through. So it is obviously a less severe form of spinal cord injury, and it results in mixed and variable motor and sensory loss at and below the levels of injury due to partial interruption of the different neural tracts. There are 4 general patterns of incomplete transection of the spinal cord. Namely, the hemisection, means one half of the spinal cord is sectioned while the other half is intact. It is also known as Brown-Sequard syndrome. A central cord syndrome means the central part of the spinal cord has got section or connection between the central part of the spinal cord is gone while the peripheral parts are still intact. An anterior cord syndrome means there is a section where the anterior part has been severed, while there is a posterior cord syndrome where the posterior part is severed. So these are the 4 general patterns of incomplete transection of the spinal cord. Among them, hemisection or Brown-Sequard syndrome is important for your purposes. This diagram depicts the different incomplete transections. As you can see, the red areas means that area of the spinal cord has been sectioned. In Brown-Sequard syndrome, exactly half of the cord is section. In anterior cord syndrome, the anterior part of the cord is section. In central syndrome, you can see the central part has been sectioned while the peripheral parts are intact, and the posterior cord, the posterior part is sectioned and the anterior part is intact. Brown-Sequard syndrome. It is also known as hemisection of the spinal cord. It was first described by Charles Edward Brown-Sequard in 1850 while studying spinal cord injuries of agricultural workers in sugarcane plantations in Mauritius. However, historically it is much more common as a war injury due to a bayonet wound on the back of retreating soldiers. However, it can also occur secondary to diseases like tuberculosis, multiple sclerosis, and spinal cord tumors. The general characteristic of Brown-Sequard syndrome is the half that is transected, there will be ipsilateral upper motor neuron type of paralysis below the level of the transection, and also loss of dorsal column sensory modalities, while on the opposite side, that is contralateral side, there will be loss of pain and temperature sensations due to cutting up of the spinothalamic pathways. This is the general characteristic of Brown-Sequard syndrome or hemisection of the spinal cord. I again repeat, below the level of the lesion or below the level of the hemisection, there will be ipsilateral upper motor neuron type of paralysis and loss of dorsal column sensory modalities. And on the opposite side or contralateral side, there will be loss of pain and temperature sensation. This table summarizes the clinical features of Brown-Sequard syndrome. As you can see from the table, I have subdivided the features into above the level of the lesion, at the level of the lesion, and below the level of the lesion. For all practical purposes, it is below the level of lesion which is most commonly asked. However, if you are answering well, sometimes to put you into a sort of dilemma, questions like what happens if there is a hemisection and above the level of the lesion and at the level of the lesion is sometimes asked. So at the level, you can see that sensory, motor as well as vasomotor effects are seen on the ipsilateral side, while on the contralateral side there are no effects. As for sensory, there will be total sensory loss, means dorsal column sensations as well as spinothalamic sensations all will be lost at the level of the lesion in Brown-Sequard syndrome, while the motor paralysis will be of a lower motor neuron type of paralysis, and due to the vasomotor tone loss, there will be a vasodilation at the level of lesion on the ipsilateral side, while on the contralateral side, since there is no lesion, there will be no affliction. Below the level, I have already said. On the ipsilateral side, there will be loss of dorsal column sensations, upper motor neuron type of paralysis and vasodilation, while on the contralateral side, there will only be loss of spinothalamic sensations like pain and temperature, while there will be no motor affliction or there will be no vasomotor affliction. Above the level of lesion, in some textbooks you will find that on the ipsilateral side there can be occasional areas of hyperesthesia. This is due to involvement of the lysoia tracts that are carrying the fibers from that level where the lesion occurs to upper levels. However, some textbooks do not mention it, while on the contralateral side there will be no effect. So to summarize, at the level of lesion there will be only ipsilateral effects, while contralateral effects are only seen on below the level of the lesion. This diagram is an example accompaniment. As you can see, as an example, right-sided hemisection of spinal cord at the level of the 12th thoracic segment has been taken, and in the diagram on the right hand side, the human figure, you can see we are being shown from the back, and on the right side, firstly at the level of the lesion there is loss of all sensation as well as lower motor neuron type of paralysis of the muscles supplied by T12 segment. Thereafter there will be lower motor neuron, upper motor neuron type of paralysis below the level on the ipsilateral side, and loss of proprioception and vibration, that is the dorsal column sensations, while on the contralateral side there will be loss of pain and temperature sensations. Lastly, I would like to elucidate in brief about the differences between upper motor neuron type of lesion and lower motor neuron type of lesion. What do we mean by upper motor neuron type of lesion, or what is upper motor neuron? Upper motor neuron is any motor structure of the neural pathway above the anterior horn cell in the spinal cord or above the motor nuclei of the cranial nerves. That is, from the cerebral cortex till the descending motor pathways, a lesion anywhere resulting in motor paralysis will be termed as an upper motor neuron type of lesion, while a lower motor type of lesion is a lesion in the anterior horn cell or the motor nuclei of the cranial nerve, their motor fibers, or the neuromuscular junction. So any lesion at the level of the anterior horn cells or below up to the neuromuscular junction is an example of lower motor neuron type of lesion, while above the anterior horn cell, that is from the cerebral cortex till the descending motor pathways, it is the upper motor neuron type of lesion. What is the most striking clinical feature in upper motor neuron type of lesion? It is the increase in tone of the muscles that is supplied by these neurons. So the muscles which are supplied by the lesion fibers will show an increased tone. It is so much increased that it becomes spastic, that is inability to move, and you can only move it with force. And when you try to move it with force, that is stretch the muscle, it undergoes repetitive contraction and relaxation involuntarily, which is known as clonus. So the presence of spasticity and clonus, which can be present, which cannot be present also, plus minus, is the pathognomonic feature of an upper motor neuron type of lesion. While in a lower motor neuron type of lesion, the tone is grossly reduced and the muscles are described as to be hypotonic. So hypotonia is the feature of lower motor neuron lesion and spasticity is a feature of upper motor neuron lesion. The next point of difference between the two is presence of muscle weakness. In an upper motor neuron lesion involving the lower limb muscles, the weakness is more marked in the flexor group of muscles, while in the upper limb the weakness is more marked in the extensor group of muscles. While in the lower motor neuron type, the weakness affects both flexors and extensors, and the distal muscles are more affected than the proximal ones. Next point is the deep tendon reflexes or simply jerks. In case of upper motor neuron lesions, the jerks are increased or exaggerated, while in the lower motor neuron lesion they are absent or reduced. One point here I would like to mention in upper motor neuron is, even though the jerks and deep tendon reflexes like knee jerk, ankle jerk, triceps jerk, biceps jerk all are increased, but certain superficial reflexes like abdominal reflex and cremasteric reflex, they are also usually absent. So it is not that only the deep reflexes are absent, but in lower motor neuron lesions these reflexes are present. One of the important feature of difference between upper and lower motor neuron lesion is the response to plantar stimulation or plantar reflex stimulation. Normally, if there is a plantar stimulation or stimulation on the plantar surface from the lateral side going towards the ball of the great toe, there is flexion of the great toe and also there is crowding in of the other toes. But in case of upper motor neuron lesion, the response is exactly opposite. There is extension of the great toe and fanning of the other toes. In case of a lower motor neuron lesion, a plantar response can be normally present but usually is absent. Next is muscle fasciculation. If a muscle whose nerve has undergone upper motor neuron type of lesion is examined, we will not find any fasciculation in the muscle fiber. But in lower motor neuron lesion involving the anterior horn cells, there will be presence of definite fasciculations. Lastly, muscle wasting. A muscle whose upper motor neuron has been lesioned usually do not show much wasting. Rather, it shows spasticity and increased tone. However, due to prolonged disuse or unuse, they may undergo wasting in later stages. But in lower motor neuron lesions, due to reduced tone hypotonia, there is marked wasting of the affected muscles from very early after the lesion. So these are the points of difference between upper motor and lower motor neuron type of lesion. So thank you once again for listening to these boring lectures with so much patience. Wish you all a advanced happy Diwali. Hope you all enjoy a COVID-free life. Thank you once again.